like John said, I've been working in diagnostics for the past 15 years, and so I worked on a test for avian influenza years ago. So I know exactly what it's like to develop the kind of test that they're producing right now, and I've definitely been keeping up with news of the virus as it comes out and trying to study things as much as I can and trying to keep up. It's difficult because things change all the time, but I've been doing my best. So because this is a shorter talk, I'm not going to give a lot of detail on the basics. I'm going to assume that you guys know the basics. I'm just going to kind of start with an update on what's going on right now, and that will kind of trigger questions. And feel free to ask questions about anything during the talk or at the end, including basics. So whatever you want to know is fine. So let me just get started here. So most of you know that coronavirus, the name, it has nothing to do with beer at all. It has to do with the fact that if you look at the virus through an electron microscope, which is the view here on the left, you can see that it has these little envelope proteins that stick out of the virus. It kind of looks like a crown. And corona is both the Spanish and the Latin word for crown. So that's where that name comes from. The official name, of course, that what everybody has been calling it is coronavirus. That's actually the name of the class of viruses, which includes a few different viruses. The actual name of this virus is SARS-CoV-2. I usually call it SARS-2. The name of the disease is COVID-19. And of course, people scramble these two together all the time. So there's a lot of confusion about what the names are. If you say coronavirus, most people will understand you, even though that's not technically correct. So this is just to kind of show you what the infected versus deaths for pandemics is. Now, this is not a useful graph because it shows the absolute numbers. And with the Spanish flu, we had so many people that had it that this is not useful. So I'm going to show you a logarithmic graph. And if you haven't seen one of these before, the numbers on the left are logarithmic. So for every step, you go up a 10-fold step. So it goes from 10 to 100 to 1,000. So it makes it easier to see a bunch of different numbers on the same page, but it emphasizes smaller numbers. So just so you know that. So you can see that for the annual flu, we have about 45 million people in the US that are infected. Around 61,000 people actually die. For the swine flu, which was in 2009, we had almost 60 million people that were infected and about 12,000 people died. So even though more people were infected, it actually turned out to be not as fatal as the annual flu, even though it caused a lot of stir. And the reason these things cause so much stir when they come out is because when they originally come out, nobody actually knows how deadly it will be or how many people will get it. So part of the reason people are always so excited about these is because no one knows what the actual parameters are. And because nobody knows, we have to kind of assume that it's going to be on the bad end or else we're going to be taken by surprise. So that's why there's always such a big stir. The Spanish flu was in 1918, and that one infected 500 million people worldwide and killed between 20 and 50 million people worldwide, which is obviously a huge number, and it changed world events, and it was a big deal. So for the original SARS, actually, it was pretty deadly, which we'll talk about. Only 8,000 people caught it. MERS, which is another coronavirus, we have little outbreaks of that every year, and about 2,000 people have caught that so far, but not very many. But I'll show you later why that's still significant. So for COVID-19, obviously, as we all know, these numbers for infections are confirmed cases. They're not actual cases because nobody knows what the actual cases are. So the best we can do is show you what the confirmed cases are, and sometimes we can make guesses as to what the actual cases are. But right now, the worldwide number is 2.7 million. 1,000 people have died so far. In China, the official number is 84,000 infected. Most people outside China say that that's not a reliable number, so we all understand that that number is not reliable. So the United States right now is 845,000. I actually can't see some of my stuff on the right because let's see if I can get rid of this. I just hid your thumbnail so I can see my graphic here, but Let me go back one. So I actually won't talk about Italy anymore. They were very newsworthy for a while, but they're not as much anymore. So I won't talk about Italy. So South Korea is interesting because they did very broad testing and they were able to tamp down things right away. So their numbers are probably pretty accurate, and they might be even accurate in terms of actual cases. So they have 11,000 cases total, and they've only had 240 people die. They did a really good job of tamping this thing down early. And if we want to study somebody, it's South Korea. So let's talk about fatality rates. And this is for deaths divided by confirmed cases. So remember, I said confirmed cases. That means these numbers are based on the number of cases we actually know. And so these death rates are going to be a little bit inflated. So the annual flu is 0.14%, which is pretty low. For the Spanish flu, the number was 2.3%, which is obviously much higher than that. For the first SARS virus, it was almost 10%. So that was in 2002, 2003. So that's pretty high. For the MERS virus, which comes around every year but doesn't infect very many people, the death rate is a very high 34%. So that's what people were afraid of when this came out. So that's just to give you some context. A lot of these new coronaviruses have some very high fatality rates. So when people got excited early on, it's because they were worried that it might be something like that. So for COVID-19, in terms of confirmed cases, the worldwide death rate right now is almost 7%. In the United States, it's 5.5%, and that's deaths divided by confirmed cases. So the basic reproduction rate is a very important number. That's the number of kind of in a calculation to figure out if the average person had the virus, how many people would they pass the virus to? And that kind of assumes that it's a virus in its natural state and people haven't done a lot to counteract it yet. And it's a population that has not seen the virus before. So that all that stuff is assumed in that number. So it's kind of native to the virus. And for the annual flu, it's 1.28. So if a person has it, they'll probably pass it to one other person. For the Spanish flu, that was almost 2 people, and that obviously had a much bigger impact. A very recent report shows that the SARS virus, R0, is 5.7, which is very high. So this is the reason why, even if the fatality rate is lower than we think, the reproduction rate is still very high, which means it's kind of explosively infectious. So we really have to keep a close eye on it so it doesn't get out of control. And that's why, even though things have started to get better, a lot of infectious disease experts are still very concerned about it. So this is a graph of daily new deaths in the United States. So we expect these numbers to continue to go up for a while. The daily new cases is flat, but the deaths continues to go up. And we had a few days where the deaths were very high. So for the cases in California, we were kind of going sideways and it was kind of flat for a while. The last few days, you'll notice that the last few days have gone up quite a bit. It's hard to say what that's from. It could be that it's because people have become more relaxed and they're going out in public more because things have been going better. Alternatively, a lot of the testing companies are trying to do a lot more testing. And so we may have had more tests coming out and results coming out, and that might be the reason for that big spike. So it's hard to know right now. So for daily new cases in the United States, it's been kind of flat for the last, really since the beginning of April, and it's much better than if it was going up. But of course, we'd love it to go down again too. And so we're obviously hoping for that. Now, the indicator things are better is that the U.S. rate of increase is continuing to go down. So that's the percentage that the new cases goes up every day. And right now, that percentage is below 5, which is excellent. But in the middle of March, you can see that percentage was up above 40%. And that was really scary because we had a lot of new cases every day. And if that rate was still that high, we would be in big trouble. So when they talk about trying to get the flatten the curve, shall we say, we want that number to be much lower. And luckily, we've been able to do that. So we're now below 5%. So let's just compare this. A lot of people are still saying, this is really more like the annual flu. And so I just want to talk a little bit about what is different between the SARS-2 virus versus the annual flu. So annual flu, the incubation time is between 2 and 4 days, the same as with the Spanish flu. With the SARS-2 virus, the incubation time is between 2 and 14 days, which is very long. And that means that people can be walking around without symptoms, but sometimes still be contagious for between 2 and 14 days. And that's a very long time. And that means that we don't know at any given moment who might be sick. And you'll hear a lot of people say, well, I'm not sick. I don't feel bad. I should be able to do whatever I want. And unfortunately, the fact is that they may be sick and not know it, or at least be infected and not know it. The fatality rate for the annual flu is 0.14%, which is pretty low. The fatality rate for the Spanish flu was between 2 and 3%. For COVID-19, these numbers are after you start taking account some of the recent studies. So there have been some recent studies where people have done antibody testing on groups of people. And this is only smaller groups. So there was a study in the Bay Area, in Santa Clara County. There was a study in Los Angeles County. And there was also a study in New York City. And based on a few of those studies, it looks like the actual fatality rate may be between 0.2 and 0.7%. So that's still higher than the flu, but it's not as bad as the Spanish flu. So we're in there in the middle somewhere, okay? So these numbers are still very early, and they will probably change. So for the base of reproductive number, like I said, for the annual flu, it's only 1.28%. For the Spanish flu, it's 1.8%. And for COVID-19, it's a very high 5.7%. So it's these top two, even if the fatality rate is lower, which is really good news, the incubation time is very long, and the basic reproduction number is very high, which is a big problem. So just let's say a few things about the new testing. Everybody's been hearing a lot about the new testing and been very curious about it. But the testing does different things, and oftentimes a lot of people, including your doctor, don't necessarily understand all the differences between the testing. So it is really important to know the difference. A lot of the tests that you've heard about, most of the tests out so far are PCR tests, and that's the kind of test that I worked on while I was Quest. And I created several tests that were really exactly like the kinds that they're producing right now. And they are about $120 in general. They have to be done at a specialized lab, so they have to be mailed in for testing. It takes about 2 days 2 or 3 days from after you mail it in, or the doctor mails it in, for you to get a result. And that's at least. If they're backlogged like they have been, it might take longer. So the target for this is viral RNA that's collected from your nose. So there have been some problems with some false negative results, and that's because the virus really lives in your lungs, and if the doctor doesn't collect enough or not in the right location, then they might do a collection and not have any actual virus, even though you have been infected. So there is about a 26% false negative rate, which is obviously something we want to minimize. The PCR test works only while you're actively infected. So while you're infected and you have virus in your nose, that's when you can detect with a PCR test. So these other two tests I'm showing here are two different kinds of antibodies that exist in your body. So your body, obviously, as you know, produces antibodies when you're sick. And the first one that gets produced in a few days is called IgM, and that antibody is produced while you're sick. And then another antibody called IgG gets produced after about 7 days, and that antibody gets produced between weeks and months, maybe even years after you're sick. So a lot of people are interested in the IgG number. These tests are much cheaper. They take a little bit longer to develop, which is why there's only about 3 or 4 that are out now. They can be done by a lot of routine labs. They take about 1 hour to perform. And what they're detecting is human antibodies against the SARS-2 virus that are floating around in your bloodstream. So this is actually a blood test. And sometimes you'll be in the doctor's office if you're really lucky and they have a lab for this, and you can give them your blood and you can sit in their waiting room and get an answer in about a half an hour. That won't be the case for most people right now, but that's a possibility in the future. So like I said, the IgM antibodies arise after about 3 days, and the IgG arise after about 7 days. So that means if you've only been sick for a day, the antibody test will not find antibody. So that'll be negative. It'll be a false negative if you test early on. I'll say too that a lot of the antibody tests that are being sold right now online have not received authorization from the FDA. They've not been tested by anybody, and a lot of them, people are warning that they're not very good. So if you really, the way to get an antibody test or a PCR test is to go through your doctor right now. Right now, there's no home test that I would trust right now. So go through your doctor, and if you do find a test that somebody wants to sell directly, you can go to the FDA site, which I'll show you later, and you can look on their list of emergency use authorization tests to see if the test you're interested is on their list. So if you the best way to do this is to take these tests in combination. That'll give you the best result. And it will also tell you something about your infection if you've been infected. So if all three of these things are negative, that means you probably have no infection. I want to say that all these tests have a possibility of either false positive or false negative results. So you should go to your doctor for interpretations of any tests, okay? And you'll have to get these tests from your doctor for now anyway. If you have a positive PCR test and a negative antibody test, it probably means you're infected, but only for a few days, or 1 or 2 or 3 days. If you have a positive PCR and a positive IgM, that means you've been infected between 3 and 7 days ago. If all three of these are positive, it means you've been infected for longer than 7 days. And if you're negative for PCR and negative for IgM, but you're positive for IgG, then you've been infected for longer than 7 days, and it may mean that you're not infected anymore. You don't have an active infection, but it means you used to be infected. And this scenario right here is what a lot of people are interested in. They want to know is, have I been infected months ago, like in December, and maybe I don't have it anymore? And a lot of people think they're in this position. But the reality is some of the studies have been done with antibodies recently have shown that maybe only as many as 4% of the LA population, for example, has been infected. So there's a lot of people who say, I want to just get off this and go back to normal. And that's only true for about 4% of people. So you're probably not in that group of people that has been infected and didn't have symptoms. So a little bit about masks. There's been a lot of confusion about masks because the CDC was saying for a while that you should not wear a mask. I think, frankly, they were saying that because masks were very difficult to buy. I still haven't been able to buy new masks since this all started. But it is a good idea to wear a mask, but it is important to know which one. So on the left is a surgical mask. That's good all those are for in surgery is to keep the doctor from coughing or sneezing or talking into an open wound. So it's really just meant to keep things from coming out of your mouth. And so these are good for protecting you, protecting other people from you. The N95 mask that has a valve is great for protecting you from other people. They filter out 95% of viruses, which is where that name comes from. But because they have this valve, if you cough and sneeze, then your cough and sneeze is going to shoot out of that valve. It makes it easier to breathe in, but it's not good for protecting other people. If you want to do both, you can get an N95 mask that does not have a valve, and it's not as comfortable to wear. But it does do both of those things. Now, the problem is if you stick your fingers in the seam, or if you mess with it all the time or whatever, then it's not going to be as useful and you might contaminate it. So it's important to put it on and then make sure those little metal tabs are tightened around your nose, and then just don't touch it until you're ready to take off, if you can do that. And then when you take it off, you want to assume that it's contaminated. There are having recent reports, if you watched the White House briefing last night, they said that UV light is good for killing virus. So my wife and I have been doing for a month or so now is we'll put our masks out in the sun for an hour or so and let the sun just kind of sterilize them. And according to them, that actually is actually an okay procedure and probably actually works. So when we talk about flattening the curve, and when I first gave this talk, it was March 13th, and a lot of people weren't convinced this is going to be a big deal. And now we all know it's a big deal, but a lot of people are getting stir crazy. They want to go back to real life. And when it comes to these kinds of things, I kind of treat it like a kitchen fire. If you have a kitchen fire and you have a little fire in your pan or something, it's not necessarily a big deal at first. If you take it with urgency, but without panic, you can put a lid on your pan and it will go away and it's not a big deal. But if you don't take care of it right away, then it can become a kitchen fire, a bigger kitchen fire, maybe even a house fire. So you quickly have to use a fire extinguisher or maybe even a fire department if things get really serious. So the key to this kind of thing is we want to take care of them quickly and with urgency, but without panic. And that's how we should really be addressing these new viruses, because initially we don't really know how they're going to behave. So that's how we want to continue to be working with this. We've all heard about this idea of flattening the curve. So the idea is just that you want to minimize the active cases so that we can minimize overwhelming our healthcare system. And I think at this point, really only the New York City healthcare system was overwhelmed, and that was only for a week or so. And other places have managed to do okay. And here in Southern California, we've managed to do okay. But we want to continue to maintain that. I'm going to skip this slide. So this graph is kind of a little bit of a hypothetical. So the blue bar shows what we actually have done. So this only goes till April 2nd. So this shows the actual numbers. We actually currently, during this graph, it was about 5%, 15%. Right now it's about 5%. So the yellow bar shows what would have been the case if we were at 30% per day this whole time. And the red bar shows what would have been the case if we remained at 40%. And remember, we were at 40% for quite some time. So that was actually a real number. We were actually at 40% until the beginning of March. So I want to talk a little bit about reopening guidelines. If you haven't heard about the guidelines that the White House produced, I want to talk just briefly about that because people are very curious. So the federal recommendations are a guideline. The governors are going to be the final arbiters of which states reopen and how they reopen. And some states will open as a state and others will reopen county by county. The White House has recommended 3 phases of opening. So advancing to first phase requires that cases are downtrending for 14 days. That has been true in several states. Right now, it's not really in California. California's been going up and down. They're doing better than before, but they're still going up at the moment. And then they want hospitals to be able to test all health care workers, including the antibody testing. What they would love is to have robust testing, meaning testing all symptomatic and even some asymptomatic people, and also doing something called contact tracing. And that's where you can find people who are sick and then actually tell people that they've been in contact with and inform them that they've been in contact with a sick person and that they should be isolated. This is actually the practice. This contact tracing is how some of these countries like South Korea, Japan, Taiwan were able to minimize their infection rate very early on. And so this is a great practice. And if we can do it, that's really what we want to be doing going forward. And also they want to make sure that hospitals have adequate PPE and surge capacity. So if you want to find these guidelines yourself, you can just do a search for federal reopening guidelines, and you'll find somewhere where you can get those guidelines. So I just want to talk about some other resources that I use in case you want to do some research yourself. So and you can search for the terms that are behind the bullet point, and you'll find the sites that I'm talking about. So the first is the Johns Hopkins University site. That's my favorite site for getting data day to day on numbers. Another good one is the Worldometer coronavirus site. They have some really nice graphs that make it kind of easy to see. Los Angeles County has a graph, has a site that will show you city by city, and even for the city of LA, will give you every neighborhood in terms of how the neighborhoods are doing. And there's a brand new site called RT Live, which I'll kind of highlight, that shows you the reproduction number kind of on a live basis for different states. So that's been a really informative one for showing how individual states are doing. And it shows this graph that shows all the states. And it also shows how California is doing. This is on the left is the RT number. So this is a number that we want that to be below 1. So above 1, it means that the virus is still spreading. Below 1 means that it's starting to contract, and people are now passing the virus to less than one person. And that's what we want. And then on the right shows the number of new cases every day. And obviously you want that to be as low as possible. And I just want to give you this slide is just a little bit of a warning, because this is showing that early on, New York State didn't take things as seriously as they could have. On March 11th, when Gavin Newsom was kind of closing down California, Bill de Blasio was encouraging people to go out and have a good time, and that did not work out for New York. And a week later, their hospital was overwhelmed, and they were burying bodies on Hart Island on a temporary basis. So New York is doing much better now, but this just kind of shows a warning as to what could happen if things don't stay under control. So I'm going to stop sharing now. Actually, I'll keep on sharing. I may have some slides that you might be interested in later. So go ahead and give me any questions that you might have.
Yeah, this is Ashley Andrews. I have a question. So right now we're flattening the curve with stay-at-home orders, but what happens when we inevitably will all resume working again? I mean, it seems like there's going to be an inevitable spike.
Well, what I'm expecting, and this is based on kind of a guess, but what I'm expecting is for the virus to go away for the summer, both because people are out more and there's more sunshine and things like that, and also because people are just being careful in general. And I expect it to kind of go away during the summer, and I expect there to be a spike in the fall. And that kind of follows a trend based on the standard flu pattern. But I'm hoping that if the United States has better testing by then, for example, if we have testing, if you can get testing just if you're afraid that you were exposed, or if we have that contact tracing idea that I talked about before, if those things are in place, even if we get virus that comes back in the fall, I'm hopeful that we'll be much better prepared next time than we were this time. This time, I have to say, we were not well prepared. The CDC likes to kind of keep control of the testing early on, and they did that this time, and that ended up, that's been fine previously in previous epidemics, but it turned out to be a mistake for this one because they just didn't have the testing capacity. And by the time they released testing for other companies, it was too late, and they kind of got caught behind the 8 ball. So, but if it comes back in the fall, I'm fairly confident that we'll be much better prepared next time.
Eric, in terms of being prepared, what does that mean for us?
So California is not ready to go back to normal. The governor has not really planned yet for reopening, and he's probably going to wait until our numbers are lower and things like that. So in terms of being prepared, so what I would say is that we want to have lots of extra capacity in hospitals. That means we want to have a lot of masks and gowns and gloves. Like most hospitals have enough right now, but they want to continue to stockpile so that there's another big rush, then they'll have a lot of extra that they can use. I would like to see much more testing. So testing is much better than it has been. And testing is enough for the sick people we have right now, but it's still not enough if we have another big surge. So we want to have enough testing that we can take care of people in a surge. And there's lots of new testing that's coming along online right now. All the companies are buying new instruments and hiring new people and all that stuff so that we can do more testing. That'll take a little while to be really great. There are 4 antibody tests that have emergency use authorization right now, and more are coming online. And so we want to have a lot of those ready to go. So that's what I'm thinking about in terms of what can we do. And also the public health needs to be ready to do that contact tracing I was talking about. So that requires some data management, computer work, infrastructure in terms of getting a hold of people. What they'll probably do is push out some kind of an app to everybody so they can communicate with people, or they might use one of those reverse 911 systems or something like that. So that's the kind of thing that we need to do in order for us to be ready.
What's your forecast on immunization?
Say that again?
What's your forecast on immunization?
Immunization.
That's a really tough one. I actually think that it's, when people were asking me this initially, I was actually wrong because, the flu virus, they make a new vaccine every year, and they do that. Usually takes them a few months. So how that works is they find out in the spring what the strain is likely to be, and they start working on it, and it's usually ready by the fall. And they actually have to grow virus in chicken eggs, and then they have to neutralize the virus, and then they have to make sure it's safe, and then they put it in a mix to send out to physicians. So that's how they do it. So it turns out the reason they can do that as fast as 4 months is because they know how flu vaccines work. But it turns out every vaccine is very different. So there's lots of different ways to put together a vaccine, and they have to do a bunch of research to figure out how we're going to do that. And I've heard one physician talking about how he was working on a vaccine, and it took them 4 years, and at the time they thought that was very fast. So people are saying next summer, but some physicians are saying that is too ambitious and too optimistic. They don't think next summer is a viable time frame. So
do you think it'll close down? Do you think it'll close down next fall?
It all depends on how ready we are. If we have the kind of preparations, let's say, that South Korea had this time, then we might be fine. I mean, South Korea either didn't close down at all, or they closed down only briefly, and they definitely had to isolate some people, but they didn't isolate their entire country like we had to. And so if we can get some of those things in place, which, like I said, I think we can do, then I think this fall might be better. But we'll have to see.
And Eric, what are your thoughts on herd immunity?
A lot of people ask about that, and I've actually never been a fan of the idea that herd immunity can protect us in general, because in order to have herd immunity to something, you have to have a lot of people who are vaccinated or have already had it. So I've heard people say, for example, measles, it has to be like 95% of the population has to be vaccinated for there to be herd immunity. And every disease is different. Measles is very infectious, so that may be why it has such a high number. But 95% is very high. And so I would say for something like the measles, I wouldn't count on, if you're thinking about your kids or your grandkids being safe, I wouldn't count on herd immunity. I would just get them vaccinated. And I realize vaccination itself is a very controversial thing these days. But in general, I would just recommend being vaccinated. Obviously, this isn't an option right now with this. So we can't say that. And I've heard people say, well, we can just wait till we all get it, and then we'll be herd immune and we'll be fine. And unfortunately, if we all get it, that still means several million people dying, even with the lower fatality rate. So we don't want to depend on everybody getting it. That's not really an option. So we want to avoid getting it if we can. And even if you're a younger, healthier person, you want to avoid getting it so you don't pass it on to your parents or grandparents, or that you don't give it to your kids, because as we all know, kids are not as careful and tidy as others would like. And they're not, if they get it on other people, they're going to pass it to them. So we just want to continue to be careful. And at this point, we want to just, obey the guidelines that is coming out of your county healthcare system.
So Dirk Hudson has a question. Let me put him on. Dirk, go ahead.
Yes. How does this pandemic compare with previous pandemics, such as the Spanish flu?
Well, the Spanish, I would say, in terms of the, I'm going to re-show my slides. Let me go back to that. I think we can go back to that. So the Spanish flu infected about 500 million people, they estimate. And it killed about 20 million people. Now, if you look at this slide that I'm showing now, so this is how it compares in terms of those three really key numbers I was telling you about. So the incubation time for the Spanish flu is 2 to 4 days. For this virus, it's 2 to 14. And this virus is much longer. And that means this virus is much worse, because that means people can be spreading the infection for much longer without knowing it. And that's a big problem. So the fatality rate is probably lower than the Spanish flu. That's good. But the basic reproduction number, which is the measure we use for how infectious it is much higher. So it's much more infectious than the Spanish flu. It has a much longer incubation time. Those things are bad. The fatality rate is maybe 5 to 10-fold less. That's good, but it's still 2 to 8 times worse than the annual flu. So it's somewhere in between. So I would say in general, the comparison to the annual flu is not a good one. It's not a good comparison to the annual flu. I'd say if you want to compare it to something, the best comparison is actually to the Spanish flu, and the Spanish flu was bad. So this is not to cause panic, but we do want to be careful, and we're doing much better than they were doing in 1918. And I think we stand to fare much better, and that's partially because we know more than they did.
I have a question. What about we're lengthening the time. Are we going to have 50% of the population infected eventually, instead of being in 1 month, having it over a year? Is that sort of, or are we going to have 90% or 100% of the population infected over a longer period of time?
Well, any number anybody gave you on this would be a guess, but I'm going to guess, and like I said, it's only a guess. I'm actually more optimistic than most, so you can take that with a grain of salt. I think it'll be less than 50. I think it might be 20 or 30. Right now in big urban areas, it's up to 4 or 5 right now by the small studies that have been done. So I think in rural areas, it'll be much less. But there are some people early on who said it might be as much as 70%. And that, if that were the case, then we would have a lot of fatalities. And I certainly hope it doesn't end up being that high. So my guess would be 20 or 30, but that's a guess. If we can get things back in line before then, I mean, look, if we're at 5 now and we continue to trend downwards, we can end up being as low as 10, which would be great. So we'll just have to see.
Thank you.
Okay, any more questions? I think a big round of applause would be in order. If you know how to do that on your screen, yeah, just excellent presentation.
We appreciate you coming. I'm going to end with one last question. So there's been evidence that that COVID-19 or SARS-2 was here much sooner than previously anticipated. What do you make of that, and what is there anything we could be doing as a result?
Well, I think The evidence mostly, from what I've heard, is mostly just people saying, gosh, I was really sick in December. And at this point, we don't really know. So these are guesses. And I mean, it certainly could be that some people were sick in December. Like I know somebody who was at somebody's house for dinner and they had some guests that were from China. So, and it's very possible that the virus was more widespread in China than anyone knew at that time. And it's possible that my friend had it in December. I don't doubt that. And there's probably a bunch of stories like that that are true. Like I said, the recent studies that they've done with antibodies show that maybe only 4% of the population in LA, for example, has had it. So I think when some people talk about the early arrival, a lot of them what they're doing is they're hopeful that a lot of people have already had it and that we already have herd immunity and that it's already kind of going away. And unfortunately, the studies we have right now saying that's not the case. We only have 4% of people that have had it now, which means there's still 96% of people in LA, for example, that are still vulnerable. So we're not at the stage where we can just say everybody's had it and we can go back to normal.
Once you've had it, do you think it's not going to come back again then? Or you think you'll have an immunity to the...
Well, just like the flu, it's an RNA virus. And RNA viruses, and this is the same with HIV, they have very poor replication machinery, and they make a lot of mistakes. And what that means is that they mutate rapidly. And so if you have a virus 1 year, it's very likely that it's going to be slightly different the next year. So you could catch it again the next year. So it may be that this may be something that will be with us for a few years. And so we'll just have to see if that's the case or not. And we won't really know that until we just see how things play out.
But for the short term, if you had it, you probably won't get it again for that particular strain. It would be a different strain.
Yes, that's probably true.
All right. Well, thank you again, Eric. Appreciate you. Nice.
Welcome, John. Good to see you.
That's great.
And thanks everybody for coming. Kelsey,